I'm going to be talking to you about dietary intake data, something quite different from what you've been hearing since morning. I'm going to present the good, the bad, and the ugly about our data. So first, I'd like to explain what is dietary data, what do we use it for, what are the traditional approach, the old approaches that many are still existing in studying this kind of data, what are the novel approaches, and I'm going to spend some time describing what our team at the in our unit, in our research unit, are doing in tackling a novel way to look at dietary data intake. I'm going to zoom into Lebanon big time. So you're going to be hearing from me Lebanese, in Lebanon, quite frequently today. So first, as the name depicts, what is dietary data intake? It's what do we eat. As simple as it sounds, as hard as it is for us to get as researchers. It's very hard to characterize somebody's diet. If I ask anyone, what have you eaten, it will be an impossible mission for them to crack it down to the nutrient level. So we collect dietary data at the national level, meaning in Lebanon, let's say, how much do we produce fruits, how much do we export, do we store, do we waste, and then we divide equally on the population. Of course, this has a big drawback because we don't all eat the same. At the household level, same. We collect data about how much the household buys, stores, wastes, and we divide over the number of people in the household. And again, this has the same problem that not everyone in the same household eat the same amount of food. And then we collect data at the individual level. We ask the person, what have you eaten? And we track it down to the individual level. And this is where most of our work is. Now, why do we get the dietary data intake? The main reason why we collect data, dietary data intake, is to link it to disease. We want to know what is that food item, nutrient, food pattern that increases, decreases the risk of cancer, cardiovascular, diabetes, hypertension. So that's the main aim. Once we know that, the next level will be we want to know who is eating what, because we want to intervene. So are the poor eating more processed food? Are the rich eating more fruits and vegetables? We want to intervene and we want to define who is eating what to be able to develop efficient interventions. So now that we have understood somehow what are our dietary data intake and what are they used for, next let me tell you what are the traditional approaches, the limitations of the traditional approach to study dietary data intake. Most of the researchers working, or quite a few of the researchers working on dietary data intake, they look at a single nutrient. So beta-carotene, vitamin C, is it good, is it bad? Fat, is it good, is it bad? And so on. So either we look at a single nutrient, at a single food. You would see researchers building their whole careers around pomegranate or garlic and their health effects. Or a food group for fruits and vegetables. Again, they would focus on that particular food and try to link it to disease and health. However, we never have a plate of vitamin C on its own. Like when you want to go out now to your lunch, you're not going to say, please put me some vitamin C, sprinkle some vitamin E, and quite a bit of protein, amino acid, this one and that one. We never do that. We eat meals. We do not eat nutrients, because these nutrients do interact with each other. So if we eat vitamin C and vitamin E, what happens? If we eat fat and a certain antioxidants, what happens? Do they stay each one on the side in our stomach and they get metabolized differently? No, they do interact with each other, either producing a symbiotic, synergistic effect. And there is some kind of philosophical drawback to that particular approach. If you eat a certain food de facto, you are missing on the other one. We are made to eat a set amount of food. So if I am eating a lot of fruits and vegetables, de facto I am missing other foods. So is the health effect based on the food I'm eating or on the food that I'm not eating? For the statistics savvy among you, and obviously listening to the previous speaker, there are quite a few here, we've got the problem of collinearity. When you plug in so many variables in a model, Many of them are collinear. A food that is high in fiber is high most of the time in vitamin C. How can we tease the effect of each one apart? So you have that problem of a large amount of variables that you want to see their effect, but they're collinear, they're correlated. Just going to give you, these are the nutrients in a food. If I was to plug these nutrients into a model, chance alone, I'm going to get some of those significant. The number of nutrients we're dealing with in a certain food is just humongous, and it's by mere chance we're going to get some of them statistically significant. So what did these limitations lead to? Our supplementation studies failed. Whether we like it, we don't like it, we have failed in supplementation studies. Take that, beta-carotene, and this is the very famous study of beta-carotene, which increased mortality. We love beta-carotene. Beautiful antioxidants, beautiful mechanisms. Give it, increases mortality. Fat, we almost adored the story of fat, increasing breast cancer, and so on. The Women Health Study, no association. Calcium and osteoporosis, that's our motto. Eat calcium, vitamin T, protects from osteoporosis. No association. So our first supplementation trials told us that it's not a one-man show. It's not that particular nutrient on its own. And this is on the scientific level. Now take a look at the Time magazine back in 1984. Cholesterol is bad. Cholesterol is killing you. Next, 1999, same, Time magazine. Low carbs diet are the best. Low carbs diet are high in cholesterol. Fine. Take a look. July 2014, eat butter. If we scientists are confused, let alone the general public, so that this situation led to a big confusion and frustration among healthcare professionals as well as among the consumers themselves. The way to go, either we go back to our labs, design another study, try to nail the fat story, and make more and more studies of single nutrients and trying to understand their effects, or for God's sake, come up with a new idea of looking at this data set. Just think outside the box. It's not a one bullet. It's not a one-man show. What is it then? So here I'm tossing in the dietary patterns approach, which is looking at a whole diet rather than a single bullet. Rather than a single nutrient, look at the whole diet. Instead of me looking at 150 food item, 160, 3,000, 30,000 nutrients, forget them, put them behind you, and look at a dietary pattern, namat غذائي, or a dietary pattern. I'm gonna do some very simple math and simple depiction of the principal component analysis that we have used in order to derive our patterns. Take our subject 1, shown on the slide. That subject will be eating chocolate, vegetables, bread, ice cream, and whatnot. This is like many food items this particular subject is consuming. In the traditional approach, I'll be projecting that subject on all these vectors and trying to understand which food increases, decreases the risk of disease. In the new approach, I look closer at these food items. What are the foods that are moving together? Well, I can see that pizzas, burgers, chocolate, ice cream, French fries are moving together. And instead of looking at all of these foods, I look at one factor, which is I call based on the food that make this factor, and probably this is a Western type of diet. I look at vegetables, fruits, burghul, breads, olive oil, and then moving together as these variables. Instead of looking at all of them, I'm gonna look at one factor, and because of the foods making it, I'm gonna call it the Lebanese pattern. So now my subject 1, instead of me being confused with a gazillion foods that this one person is eating and a gazillion nutrients, forget them. I'm gonna look at 2 patterns or 2 dietary intake patterns, and I'm gonna project that intake on 2 patterns rather than the whole. We have picked up this novel approach in our unit, and we have decided to go forward. In 2011, we have looked at patterns and obesity among adults. We have looked at type 2 diabetes, metabolic syndrome among adults, multiple sclerosis. We have done a few reviews. We have looked at obesity among adolescents and dietary patterns. We have looked at the oropharyngeal cancer with our colleagues from Syria. We have looked at adequacy among elderly. And we have looked at dietary patterns among and its association with metabolic health among obese. From all these studies, the population is eating two main patterns, the Western and the Lebanese, as I have said before, and these are the foods that characterize them. The Western fast food, meat and poultry, sweets and sugar-sweetened beverages, butter and mayonnaise. Traditional Lebanese diet, and these are the foods making it with more fruits, vegetables, legumes, olive oil, whole dairy, eggs, grains, nuts and seeds, and traditional sweets. So we have depicted these two patterns. Next, what are their health effects? Association of these patterns with the health effect. On the y-axis, you will have the odds of the abnormality. On the x-axis, you have the adherence to the pattern. So the more we go to the left, the more we adhere to the pattern. You can see that only adherence to the Western increases hyperglycemia. Lebanese doesn't do anything. Only the Western increases obesity among adolescents. Lebanese doesn't do anything again. Only the Western increases the odds of cancer, for oropharyngeal cancer. Only the Western increases the risk of metabolic syndrome, and our Lebanese is not harmful. So as a summary of these results, you can look at that slide and you can say our diet compared to the Western is a good diet. The Western is the one increasing the odds of the diseases. And if you look a bit closer to that slide with dim lights, or just try to shut down your eyes a little bit, you can see our map. Where are we on the map? And you can see the Mediterranean behind us, behind the map of Lebanon. So we have done this exercise, and we're like, maybe our diet is a Mediterranean diet. Now, for those of you who are in the field of nutrition would know that the Mediterranean diet is a huge concept that has been dealt with over and over in the literature. So we looked at the literature and we've seen no consistent definition of what is a Mediterranean diet. And the only definition that we were able to see is that it's that diet that dominates olive tree growing land around the Mediterranean basin. And we have found evidence compelling that Mediterranean diet is protective from many diseases. So when we looked at the map again, definition of Mediterranean diet comes from Greece, Italy, southern France, and Spain. Really nothing was coming from the east side of the Mediterranean basin. Though we're Mediterranean, but no index was tossed in. No diet from any of those countries was tossed in as a Mediterranean diet. So here comes our study. We wanted to present the Lebanese diet as a variant of the Mediterranean diet, but this time from the east side of the Mediterranean basin. We have done this study. Now, if you tell me what to eat, we have developed an index to operationalize our diet. Tell me what to eat, I will tell you how Lebanese you are. So, only in relation to food intake. So, I can give you a score over 27 because the Lebanese diet is made up of 9 food groups. We divided them into tertile. If you eat more of that food, you take a 3. If you eat less, you take a 2 and then a 1 to a maximum of 27, a minimum of 9. And that index now can assess how adherent you are to your diet, to your Lebanese diet. We wanted to compare that diet with the already available indices. Like, are we in line with the others? Yes, we are. Our diet really correlates nicely with all the other indices tossed in. And in this slide, I show the correlation, the Pearson correlation coefficients between our index and the indices proposed by France, Italy, Greece, and the EPIC Europe. The highest was found with Italy. So we were very, very happy to bring the definition to the east side of the Mediterranean, proposing our own diet as a Lebanese Mediterranean diet. What does that mean? With that proposition, by proposing that diet as a Mediterranean diet, we encourage the consumption of local food, we slow the nutrition transition that we're having, we decrease the risk of obesity and other non-communicable diseases, less cost. Our Lebanese diet is not that costly. At the national level, we expose our heritage, we increase tourism and agriculture, and we encourage the local food production. Next. So what was our next step? Now, we're very happy. Our Lebanese diet is published in the European Journal of Nutrition as a Mediterranean diet. The next question was, is it sustainable? You know, in the light of the recent sustainable development goals that were tossed in, is our diet sustainable? If I recommend the consumption of these 9 food groups, is it good for the planet? Is it good for Earth? Is it good for greenhouse gases? Is it good for the water, for the seawater, for the forestry? Will it end hunger? So our next step was to calculate or to devise metrics to see whether the diet that we're proposing is healthy for us, but also healthy for our ecosystem. I'd like to acknowledge all the team I'm part of, which is headed by our own dean, Dean Nahla Hwala, and with our colleagues. I want to thank all the collaborators from all the countries, from Syria, from Iran, and I'd like to acknowledge the National Center for Research and the WHO for funding us. Thank you.
Thank you very much. This was a wonderful presentation. Before lunch, we can eat
Yeah,
peacefully.
you can eat your Lebanese. I hope
right.
There is Lebanese food out there.